Hello everybody, and thank you for joining us today online in these unusual circumstances. But one thing of us hosting this online, I'm delighted to welcome many of our overseas participants who perhaps would have struggled to travel to the UK to attend a meeting for one day. So welcome to all our overseas participants, and I hope you're enjoying it, and it would be really nice to get your feedback on these sessions at the end of the day. But now I'm going to have the pleasure of introducing our guest speaker, Ines Ushiro Ines Ushiro Lumb. She's the lead consultant microbiologist for organ donation and transplant, which is part of the National Health Service Blood and Transplant, and is the clinical director for the National Transfusion Microbiology Reference Laboratory. She's also a consultant virologist in the Virus Reference Division of the National Infection Services of Public Health England. So she comes with many great credentials to give us our next presentation, during which Ines is going to cover the general concepts about the selection of SARS-CoV-2 genetic variants and the potential impact of these evolving lineages, which we all hear so much about in the press. It will also contain a synopsis of the rollout of the vaccination programme, real-world data on vaccine efficacy, and significant adverse events. I'm sure we're all looking forward to this presentation. So thank you, Ines.
Hi. Good morning, good afternoon, good evening, everybody, wherever you are. So many thanks for asking me to join you today. So what we will do is to, well, first of all, I suppose I'll try to share my screen into presentation mode. There you go. So you should be able to see that. What we will try and do today in this session is to cover some aspects of SARS-CoV-2, its variants, the vaccine and the vaccine rollout in the UK. Of course, very aware that the membership of this meeting here, the audience, is international outside the UK too. So hopefully you will see that just by using our UK rollout vaccination program rollout experience, it's just as a matter of example, because the principles and the core thinking, the virological aspects, etc. Can be applied in any setting. So all we need to do is transport that into your local epidemiology, the phase of the pandemic that your country or your region is undergoing. And of course, there will be different vaccines being used, but it is I think the fundamental thinking process that I think is more important to share, and I do hope you find this of some use. The other thing to mention before I start is also that because most of us here, if not all of us, are working in transplantation, be it solid organ transplantation or cell transplantation, I have inserted here and there a few topics or some links into the field of transplantation, but the talk itself, the presentation itself, has not focused on the subject of SARS-CoV-2 in transplantation. If we do have time later on, maybe, and if there are questions around that, we can discuss those aspects too. Now, lastly, I think I'm conscious of the fact that some of you in the audience might have already heard or my previous talks on the subject of SARS-CoV-2. So there will be some overlap of slides, inevitable due to the nature of the talk. However, it's not a duplicate. So hang it in there because there will be different aspects covered too, hopefully. Okay, so with that said, let's just get to my first slide. And for the benefit of all, to set the scene, and particularly for those who are from outside of the UK, let's go through some very brief timeline so that we can see how things have evolved. So in the UK regulator's emergency use authorization, happened in the following order. So back in December, early December last year, we had the Pfizer-BioNTech mRNA vaccine authorized for use, followed by early January, the Chadox AstraZeneca vaccine. And then the last one to be approved was the mRNA-based Moderna vaccine. We have only just started using the Moderna, so any data that we are sharing here alludes to the first two types of vaccine. So the UK vaccine program is a phase-based one, and we use a priority group order to deliver the doses of the vaccine. And as soon as the program started, the data on effectiveness in the general population, so the real-world data, we started to be collected. And right from the outset, and it continues to be so, we are still debating and discussing the effectiveness issues around the vaccine in vulnerable groups of individuals, particularly the immunocompromised, i.e. also the transplant recipient group of patients. It wasn't too long after the rollout of the program early in December that we hit our first hurdle. So the first challenge was the fact that we then realized that it was a variant of the virus. For us, it was the B117, and we'll talk about those variants in a moment, that caused concern. So despite of the fact that we were in lockdown, there was a very rapid spread of the virus, and that led to some modifications of the vaccine rollout. And here is one that actually was pretty relevant. So the doses that were planned to be delivered according to the clinical trials were changed. So we postponed the second dose of the vaccine to 10 to 12 weeks after the first dose. And that was done to enable the maximum number of individuals to receive the first dose of vaccine at speed. Then I think it was around February, so it was early this year, where we then had some kind of relaxation and a review of that guidance, allowing clinicians, together with their patients, to then decide to bring their second dose forward, more akin to the initial plan, so that the second dose could be given in a more clinically relevant manner, particularly if there was a plan to starting immunocompromising therapy, a transplant, etc. So that was a significant and very welcome change there, allowing the shorter interval between the doses for particular groups of individuals based on their risks. Also of note, we should mention that in our case, the MHRA, which is our the authority here that oversees the responsible authority that is responsible for monitoring the vaccine usage too, as it is the same for all other medicinal products. They put in there a specific platform for users to be able to report adverse events specifically related to the COVID-19 vaccine. So here is just an aside, just to remind us that when the pandemic was declared on the 11th of March 2020, it was just a few days later when NHSBT was able to launch a screening program, a screening mechanism for the disease organ donors in terms of looking for the presence of SARS-CoV-2 RNA in respiratory specimen. This is constitutes a completely separate talk, but I just thought to mention it there, and we can pick that up later on, just in terms of wrapping up the context of organ donation and transplantation in relation to SARS-CoV-2. So in terms of the vaccine surveillance strategy, this is a very comprehensive real-world post-implementation surveillance system. So this is led by independent public health agencies, obviously not with the involvement of the manufacturers, and is there to monitor the program and to evaluate the impact on public health. So the vaccine effectiveness is just one component of such a comprehensive surveillance system. And to that end, the public health authorities are the ones in the UK responsible for looking after that. So in England, for instance, the Public Health England uses several tools and parameters to monitor the effectiveness. Some of them are just the simple ones are here listed. For example, laboratory confirmed cases in vaccine. So you receive the vaccine and then you go on to develop an infection. You have that proven through by RNA detection or seroconversion if you had a symptomatic illness, or even through an antigen detection. So it's just the confirmation that an infection has ensued following a vaccine, 1 or 2 doses of the vaccine. Markers of infections are of relevance too, because we are interested in looking at the transmissibility of the virus in those who go on to develop infection despite the vaccine. So one can look at the viral load, the amount of virus present in the respiratory secretion being tested, type of threshold values, for instance, to give you a semi-quantitative idea. And of course, in some cases, the ability to culture the virus in a viable form, of course, from those specimens. Hospitalization and mortality rates are obvious parameters to be monitoring, and so is the onwards person-to-person transmission of the virus, because that is something that we do hope that the vaccines are able to interrupt too. So in terms of the SARS-CoV genetic variants, the question that comes up very, very frequently, well, why is this virus changing? So what is actually happening? Why are we facing this? Well, let's remind ourselves that mutations arise all the time in the background, because that's part of the natural virus replication cycles. So what happens is that there may be a natural selection process that will determine what's happening to those mutations that are naturally arising in the background. So if a subpopulation of viruses, subspecies of virus, happens to then pick up a particular mutation, or more often a combination of mutations, that confer then a competitive advantage, be it because there is then, as a result of that, increased viral replication, or they are more easily transmissible, or it confers an ability for those viruses to actually dodge and escape the host immune response. That will then confer them some advantage, and then will then facilitate those subspecies to start growing in frequency, and to a point where they can even displace previously existing dominant species of virus. So that is what's actually dynamically happened. And for those working in the HIV field, for example, that's something that we are very familiar with. Now, on the other hand, if those changes in the genetic code of the virus and the phenotype of the virus is not really conferring any fitness advantage, those subpopulation may well die off, and that's usually what happens. So there are other means of retaining certain patterns of mutation that are nothing to do with the selection or selective pressure, be it, for instance, immunological pressure, but there is the concept of founder effect. So those things taken together is what they leads to kind of the shaping up of virus populations and subpopulations within individuals, within communities, groups, countries, and regions. And that's what is actually, in a nutshell, what's happening to these. What I have done in this slide is to give you a diagrammatic representation of the spike protein of some of those viruses that have evolved. So here are 3. Currently in the UK, we have 5 variants of concern and 8 variants under investigation. And I represented 3 of them. The spike protein here we have the region of the receptor binding domain, which attracts a lot of scientific interest for obvious reasons, because this is the part of the spike protein that's interacting with the human cellular receptors, and also is amenable to the effects and the binding to antibodies, be it neutralizing or non-neutralizing antibodies. Therefore, changes in these regions may be crucial or may not be crucial for those interactions to happen. So therefore, resulting either in increased ability to interact with cellular receptors and facilitate the infection, or maybe because it will allow the virus to then escape from existing immunological responses within the host. So the annotated numbers here indicate the mutations and deletions that have happened, and there is a particular set of changes that define the lineages. So the B117 is the one that was first described in England, the B1351 first described in South Africa, and the B1 first described in Japan, but in individuals who had just returned from Brazil. So there are the two that I will show you in a list. And you can see here that I've also circled or marked. Some of the mutations are shared across the different lineages. And if you think that those lineages have co-evolved completely independently in different regions of the globe, and do have some mutations that are common, which indicates and flags the reason behind it, that there must be a selective pressure that is actually selecting the particular subpopulations of virus that contain those common mutations. So this is leading me to say that those are some of the reasons, and there is a series of reasons why certain mutant viruses and variants become of interest. So they're starting to be monitored, and then they turn into variants of concern. Let me see here what I've got in the next slide. Yes, I decided to put this here just as an example. There is an extensive list of variants, of course, but some are of greater interest than others. And this is very topical because the variant first described in India, named B1617, that we then realized that genetically they actually are sublineages. So the 617, 0.2, and 0.3. So they were reported, as I just said, from India, but also in other countries, including us here in the UK, in the United States, Singapore, and 14 other countries, in much lower numbers, of course. Why are they of interest right now? Is because of the upsurge of cases in India and the rapid spread of such variants. So they do indeed contain mutations that, in theory, from what we know about the structure of the virus, could potentially modulate transmissibility of the virus, increase binding to the ACE2 receptors, etc. But in fact, to date, we don't have yet real-world data supporting or refuting the role of such mutations in terms of immune escape, transmissibility, or link to any kind of increased severity of illness. So this is why they do need monitoring, and we do need to understand a little bit more about them. So all three sublineages have been found in parts of England, but particularly the sublineage 2 was found in much quicker than the other ones, certainly here, with repeated point of importations. So the vast majority of those positive swaps showing those variants were in individuals who had returned back to the UK from India. There is some level of in-country transmissibility, i.e. people who have not had a travel history but do have those variants. And this is exactly what we need to be very careful about. So the concerns around that is the rapid spread in India, multiple imports in the UK, as I just have said, limited data as to what exactly these variants signify, and because we know that in theory and virologically, some of those mutations may indeed be problematic. So I've just used this as an example as to how one goes, I mean, the public health authorities go on about deciding what to do, why, and the criteria to class them as of significance. And when that happens, the action is immediate, is suppress the transmission locally. So here we are talking about the UK, but it would have happened in any other country because what we need to test identify them quickly, establish which variants they are, contact trace, and try to prevent onward transmissions. So here is a table that I have taken from the Gov.uk website. Is updated on a regular basis, and I have just highlighted in pink the ones that are have been denominated as variants of concern, and the ones in white are the variants still under investigation. And this was the one that mostly recently joined the list of variants of concern. The numbers are not absolute. It doesn't mean that we have 520 positive variants of this particular lineage in the UK, because, as you know, not all positive results lead to then the sequencing of those samples. But the UK has got a huge capability in terms of sequencing, and we are at a very good 50% of all positive swabs or samples are being sequenced, which is actually extremely good. So this doesn't give you the absolute number, but it gives you the relative number, showing that the variant sublineage 2 is taken off much quicker than the other ones. Now, so when we talk about evolving virus lineages, immediately we're going to be thinking about immune escape. So what is the real life consequences of that? So we're going to be thinking, well, do the sera from people who have already been infected and recovered from the original SARS-CoV-2 virus, they do have antibodies, and what happens there? Do they neutralize the new variants? Are we going to be more likely to get reinfections? So in terms of the vaccines, do the vaccines based on the original Wuhan strain, which all the vaccines are currently, do they work against the new upcoming and any new future variants? And also we do have the usage of the monoclonal preparations that have been manufactured, not just one, but a cocktail of different monoclonal antibodies against very crucial antigenic sites. What is going to happen then in terms of their efficacy against new variants? So this is the one aspect of it, but also let's not forget that when the virus changes and evolves, we also need, and for this audience particularly, I think that you'd be interested, that we do need to monitor the diagnostic impact of such mutations. So in terms of the first point, let's just volunteer here some alternative strategies to cope with that. So in terms of the vaccines and the variants, some examples. We could booster, so you give a primary, the first dose, and then you come with the second, third, or fourth dose, however many boosters we need to receive. That is adapted, better adapted and suited to cope with new variants, if that is the case, if the need arises. So, or one could come and use different vaccines for priming and boosting, and they mix and match of AstraZeneca and Pfizer, or Pfizer and AstraZeneca, and this is already in clinical trials, by the way. Or you could come up with a solution of combination of vaccines against different strains in one shot. And if you think that the seasonal influenza vaccination is exactly that. So every year we have an adapted kind of better suited for the season, a composition of vaccine that has 2 strains for influenza A and 1 influenza B. So this is the idea here. One can obviously use different antigen targets. The vaccine that we currently use in the UK target the spike protein. Other countries are using whole virus, inactivated whole virus vaccines, and there could be vaccines against different parts of the proteins of the virus too, just to broaden it up, the immunological response there and protection. Also, vaccines to elicit mucosal immunity can be developed. So this is just some of the options available. Now, in terms of the assay monitoring program, the Public Health England started doing the work, and then it's under the responsibility of public health authorities and MHRA to actually continue to monitor the performance of the assays that we use, in able to be sure and confident that they are still doing what they're supposed to do. So that is applies to antibody tests, antigen tests, and molecular-based tests, of course. So I wanted to put here just as a out of interest an example here that initially when we were first facing the discovery of the impact of the B117, which is the variant that predominates here in the UK. It did so back at the end of last year, and it still remains the most commonly infecting strain. The fact that B117 happens to have a deletion, so in the residue 6970, but this is not specific of this variant. It's present in other strains too, but because that was present, what happened is that our huge high throughput labs, lighthouse labs that were using a particular platform targeting the S gene target, but this region was not the only target, but one of the primers and probes were directed in this region. So what happened there? That was this phenomenon of very reproducible target amplification failure. So they were going negative. So, and that was very good because it was giving us a very strong signal and a very easy signal to be detected that we were seeing something that was different. So here's just an example when we were first faced with this problem, that these are the different regions in England. So it's a bit small, but it's just the names of the different regions. The bars here are showing the number of positive samples, but I just want to draw your attention here to the red line. The red line is just showing the percentage of the positive samples that we had that actually had this dropout signal. So basically nearly 100%. And just to show that the B117 variant of concern just wiped across the country very quickly and became the dominant one. And this was a very quick and easy way to have it to use it as a surrogate marker for the B117. And now, just for reassurance, of course, that doesn't mean that all our assays would start to be missing all those variants, because as you know, when those molecular-based assays are put together, we don't actually target just single places. So we target the different genes or different regions within the same gene, and most if not all the tests are used. I mean, all of the tests that are used do not have single target for obvious reasons. Okay. So then, yes, we do then monitor the RNA amplification methods. There is a risk level assessment, and the labs were very quickly instructed and guided as to how to watch out for the particular problems that they could be faced with as regards to the newly upcoming variants. So looking at shifts in CT values, increased disparity because the PCR is targeting different genes, and you're expected to see drop-offs or changes in CT, particularly against spike. Then that all were flags to kind of review your assay. And of course, then that became something very useful, and that's what we are using currently. That we have those assays that we are looking at, particularly SNPs, because we do know the sequences, we know where the variants of concerns and under investigations are. So we use then the assays that are designed to be able to pick those up at screening level very quickly. Instead of having to wait for the 4 or 5 days to sequence, we can actually get much quicker results in terms of screening for potential variants, and then acting very quickly in terms of contact tracing and isolation. Now, so the same thing will apply across, as I said, different type of assays. Here we are seeing the lateral flow devices, all using nucleocapsid antigen, and they still detect the virus. And I didn't put any slides in terms of the serological test, but of course they're also being monitored. Now let's move on to the vaccine efficacy data. And on purpose, I didn't actually put any of those examples of publications looking at laboratory-based pseudotype virus neutralization, because what that does, it just looks at single mutations, two mutations, or a combination of some of mutation of those variants. in the laboratory context. And it doesn't give you the real world vaccine efficacy data. And this is what I'm going to concentrate on here. Just 2 or 3 quick examples, because that's what we want to know. So is it working, or how is it working? So I'll just give an example here of the Siren study, which is very powerful in terms of the number of that they managed to recruit. This is healthcare workers recruited to immunity and reinfection evaluation by Public Health England. When they looked at, before this publication, this is several months old already, they could state that natural infection in those healthy healthcare workers was leading to 83% protection against reinfection. And that protection it was lasting for at least 5 months, because that was the time point when they analyzed the data. And when the vaccine rollout started, they could also see that the figures from clinical trials were still holding, because the Pfizer-BioNTech vaccine, the first dose of the Pfizer-BioNTech vaccine given to this cohort of individuals, was leading to 72% effectiveness about 3 weeks after the first dose. And for those who had then received the second dose, which was a smaller number, that figure went up to 86% as per measures around a week after the second dose. And then, of course, the claim can be made that the vaccine was working against the B.1.1.7 variant of concern, because that was and still is the predominant infection strain in this country. So moving away from the cohort of healthcare workers, here is the looking at a different cohort, the over 70s, because they were the first ones to receive the vaccine here. And we can look at data from both the Pfizer and the AstraZeneca vaccine. So again, the figures are still holding. A single dose of either vaccine is 60 to 73% effective in preventing symptomatic disease, and 8% effective in preventing hospitalization. For the Pfizer vaccine, we can say that 85% effectiveness in preventing death. It can be ascertained, and the numbers for the Chadox AstraZeneca vaccine are still putting together, because obviously we start using the AstraZeneca later than after the Pfizer vaccine. Then I think it's fair to say that the impact of the COVID-19 vaccination to this point is demonstrating that there has been a significant impact on severe disease, COVID-19 disease in England, that goes beyond the effect of the national lockdown per se. So by the end of March, there was an estimation that over 10,000 lives were, well, I was going to say lives were saved, actually deaths were prevented by the rollout of the vaccine program. So there is an increasing evidence too that both vaccines that are being used here prevent infection and as well as transmission. And the true value of these vaccines may be more in terms of prevention of future deaths that would have occurred if we were to have another spike in transmission in the future. As I said, I would mention a few things about transplantation, but this is just out of interest. There are some publications around the immunogenicity of the SARS-CoV-2 vaccine in the context of solid organ transplant recipients. So again, I think it's pretty fair to say that there are no surprises here. You know, in the clinical setting, we are fairly well familiar and experienced in terms of infectious diseases, and when it comes to vaccinating our immunocompromised groups of patients against such agents, that there is a decreased response in comparison to the immunocompetent population. So maybe the hope or the expectation that completely different platforms of vaccines, such as the mRNA vaccine or a vector-based vaccine, would lead us to something slightly different. Maybe this still should be demonstrated, but it's not surprising me that we are seeing very low seroconversion rates. But you know, despite of the fact that this is not a surprising thing, we need to learn and understand what is actually happening so that we can then come in with some plans how to tailor-make things for our patients. I'll come back to that concept in a moment. And here I'm putting here as an example. This is a very small study. There are lots of limitations around it, but I thought it was just as a nice example to show a different group of immunocompromised patients. So here we have the solid malignancies and the hematological malignancies. And the attempt here of this, I think there's 3 or 4 centers in London coming together to look at the immunoefficacy of the Pfizer vaccine in this group of individuals by looking at antibody seroconversion. So if the vaccine has got the spike protein as an antigen there, so they look at seroconversion to spike protein. Of course, a positive antibody to spike doesn't mean you responded to the vaccine because it could have had the infection. So we're looking at baseline and seroconversion. T-cell response, of course, very important. Neutralization antibody titers against the Wuhan original strain, as well as the variant of concern B117. And importantly, is whenever possible, is valid and very relevant to look at sequential sampling of respiratory swabs, because what we need to see is following vaccination, are individuals still becoming infected, are still shedding the virus, are they going to become symptomatic, or are they going to remain asymptomatic infected? So again, numbers very small. This is just preliminary, so it's very difficult to say anything. But just for illustration purposes here, the health control group, it has a very good response after first dose, after second dose. The solid malignancy one, not so good after the first dose, but a really very, very good one after the second dose. Unfortunately, the hematological malignancy portion of it, the numbers are too small, so they can't really analyze the data as of yet. But interestingly, they did say that nobody has had a positive swab after day 21 post-vaccination. Okay, so this is a different way of looking at vaccine efficacy. The example I'm giving here is our own by using our National Solid Organ Transplant database that contains information on individuals who have got a functioning graft, also including individuals who are awaiting for a organ transplant. So since April, May last year, we have been doing a linkage between our data set here and the National Laboratory Reporting System. Therefore, every single individual in this database who has had a positive diagnosis of SARS-CoV-2 infection will be cross-linked, and we will be able to monitor the outcomes there. So now with the advent of the vaccine database, we have the nationalization database. The triangulation here will then give us the data about vaccine uptake, the vaccine type received, and should we have other information, we can then relate to the fact as to whether they have received, when they have received it, have they become antibody positive, has the antibody declined, and because we can see that if infections are happening despite of the vaccination, is to do with infection, waning immunity, is this a viral vaccine escape, etc. So, and of course, these databases can be replaced with different registries, for instance, stem cells or any other groups of interest. Okay, moving on to adverse events monitoring, which we mentioned on the first slide. The adverse events monitoring did detect a very strong signal, and this is what I'm going to concentrate on. I'm not going to be talking about the reporting systems or other events that had very low signal there. So let's concentrate on what people have been hearing a lot about recently. Before we do that, a little bit of a context, so that we have to remember that over 50 million people have received the first dose of vaccine, and many of those were actually the AstraZeneca vaccine. So that said, then we can then mention that this recently recognized condition that was picked up on people who have recently received the vaccine, we haven't yet been able to identify a clear signal for a risk factor. So the cases present usually between 5 to 28 days after the first dose of the vaccine, most frequently between 6-7 days and the second week, with thrombocytopenia, progressive thrombosis. The thrombosis tends to be at unusual sites, particularly the cerebrovenous sinus, but also thrombosis in the portal hepatic vein have been seen, and other vascular beds can be affected too. The bleeding can be significant and unexpected. Now, there are typical laboratory features that come with it, and together they form this case definition. Of course, low platelet counts, very raised D-dimer levels, and low fibrinogen levels. Antibodies to platelet are also detectable in those cases. So the vaccine-induced thrombosis with thrombocytopenia, VITS for short, and this is a terminology that we have been using, has been then defined and detected in hundreds of individuals in the UK. So the figures are out there in the public domain. These are already outdated by a few weeks, so the numbers have gone up slightly, but it just gives you a flavor of the magnitude that over 240 cases, suspected cases, had been reported to MHRA. So they go then through a process of assigning a possible, probable, or proven case. They had all received the first dose of the AstraZeneca. The fatality rate is around 20%, mostly commonly seen if individuals present with the cerebrovenous sinus thrombosis, CVST. And the overall case incidence is believed to be currently around 10 cases per million doses of the first dose of vaccine. They have all been linked to the first dose of AstraZeneca vaccine. That doesn't mean that all vaccines used there's any bias in terms of follow-up and monitoring. All vaccines are being equally monitored. The cases have been seen in all age groups from 18 to 93 years of age, that, if I remember correctly, and both genders are being affected. However, it is just true to say that there is this incidence here in the younger age group that has to be balanced against the risk of those individuals in those lower age groups. Should they go on to develop COVID-19, what would be the risk of them developing severe COVID? And that balance has to be struck and be used to guide policies, so much so that those in this country will know that recently there has been a slight change in the policy that individuals aged 30 and under, if they had not received the vaccine or the first dose of vaccine already, they will be offered an alternative vaccine. And those aged between 30 and 39, also when being called for the first dose of vaccine, they should have an opportunity to receive a different vaccine, provided that doesn't actually delay or preclude the ability to receive such vaccine. Overall, it's important to say that the advice remains that the benefits of the vaccine far outweighs the risk for in the majority of individuals, certainly those that we have just discussed here. So just a very brief mention here in terms of the immunocompromised patients, because again, these questions come up to us all the time. I mean, should we be doing anything different at the moment in terms of immunizing our immunocompromised group of patients? The straight answer is no. So vaccination is per approved schedule until evidence comes that can guide us better on the basis of scientific rationale, clinical experience. So this is what we do. We just carry on as per norm. So there is no flags or strong indications that one vaccine is preferable to the other. Of course, in the immunocompromised group, provided that one is not using a live virus vaccine or non-replicating or a replicating virus vaccine, which is not the case here in the UK. So importantly, the vaccination in the general population is the most important thing to do, because by decreasing the numbers in the community, transmissibility, you then are decreasing the possibility of exposure to the virus in the first place. So that's, then one can go one step further in terms of looking at vaccinating carers and immediate close contacts to indirectly protect our vulnerable patients. And for those individuals who are immunocompromised, of course, the big message is that you have to continue with the precautionary measures. We do know, again, it's not new, that the responses to the vaccine will be lower than compared to the non-immunocompromised individuals. So, as I said before, we will accrue information, and that knowledge will then ultimately and hopefully lead us to, in the same way that other vaccines that we use for our patients, maybe we will then be able to come up with different dosing and use the timing of the vaccination in relation to the immunocompromising treatment that's going to be delivered, the usage of boosters, etc. So that will in due course. So take-home messages. Probably obvious here that the currently available highly effective vaccines are predicted to tolerate, to a certain extent, some variation in the virus. So even if you don't have that maximum efficacy of the vaccine, the protection against the most form of severe disease is expected. And maybe we could even push that a little bit further and say, even within the immunocompromised hosts, the level of response of the vaccine, and let's not forget, this is the comprehensive response, a cellular and humoral response too, that some protection is bound to happen there, as it happens with other vaccines, hepatitis B being a classical one. You don't detect high levels of antibodies in certain groups of individuals, but we are still protecting them against chronic hepatitis B infection. So let's just kind of think in the same way, although obviously that will probably certainly not hold true for the individuals at maximum levels of immunocompromise. There is a whole spectrum of different groups of patients that we are talking about here. This is very complex. Now, so what do we do then? So in the meantime, we should continue to vaccinate as many people as possible, never miss an opportunity to vaccinate individuals, and never miss an opportunity to receive the vaccine yourselves. And in the overall sense, this is putting vaccine aside in terms of, because I said I was going to mention this, in terms of the overall safety of organs, tissues, and cell transplantations in relation to both donors and recipients, we have put in place many measures to mitigate those risks. This is a subject to completely different talk, but even with the use of a vaccine, or that we are in a much better place now, and hopefully we are starting to see the control and going to be moving from a pandemic phase to an endemic phase. And as it happens in the transplant field, we will continue just to use evidence. This is a rapidly changing field, so we have to keep abreast with the scientific developments there, and use that to inform our kind of informed, as much as possible, risk assessment of benefit and risks to our patients. So I think there is no other way to actually do this in the field of transplantation. But I will stop here. I have just hit the 40 minutes, and I will take questions later if there are any. Thank you very much for your kind attention, and have a good day.
Okay.
I'm going to stop sharing now.
Thank you, Ines. That was a really fascinating insight into how the vaccines are progressing, and how there's real scientific study into the vaccines, particularly with the impact on the diagnostics. So I do have one question in the chat. So the question is if the B1.1.7 variant is now the predominant strain in the UK, and the vaccines are protective against it, when does it stop being a variant of concern?
Well, I don't know when they're going to downgrade it, but of course we are still in the pandemic, and there's still many other variants coming along. I do understand the base of the question. So the fact that there is response we are satisfied with it, doesn't mean that response is, is optimal. So we will continue to follow that. At some point, they may well be a downgrade. We haven't seen any of the variants that made into the top list coming down again. So I think we have to move slowly on that one. But yeah, I see the basis of the question. I don't have an answer, but I think they will be at one point.
Okay, so perhaps I can be indulged with a question while people are thinking. So you touched a little bit on T-cell immunity at the end, but I was just wondering what studies were being undertaken in terms of T-cell immunity and how important that is in protecting against the virus, perhaps in either the absence of antibodies or in waning antibodies in terms of a memory response.
Yes, absolutely. That's exactly the crucial point, is the memory response, and it totally they are fundamental for that. So there are many groups, of course, looking exactly from that viewpoint, the aspects, and there is a very broad response that matures with time. So it's very good news. There are many very good papers showing the very broad response, and as time goes by, the broadening of that response against different antigens and epitopes. So it's all very good news. So that's a very important component. So it's the innate response and the immune memory. So unfortunately, that's very good news for all of us, but not so exciting when we do think about our immunocompromised patients, because that's exactly where they are actually lacking the ability to respond. So there is a gap there. Therefore, to fill that gap, there's, in the meantime, there's all those possibilities of giving them passive immunity through monoclonal antibodies, etc. So there's a vast portfolio of things that can be looked upon. But yes, cellular immune response, there's a lot of work ongoing, and particularly also in our group of patients, because it's all very well checking for antibody seroconversion to the vaccine and seeing, well, it's only 17%, but we wanted to see the other components as well, because together they are likely to, as I said before, protect against the most severe forms of the disease. And I think that's probably what we really want to see happening. But yeah, there is a lot of work on that. I didn't put any of that here because there is a huge array of very interesting papers.
We got any other? There's no other questions coming through, so maybe I might be indulged then with one more question. We've heard reports about people who have immunity, sort of natural immunity, because of cross reactions with other viruses they have encountered during their lifetime, and there's been anecdotal reports of people in the same household with one individuals very severely affected and others not affected at all. Has there been any work looking at what viruses has generated that similarity and that ability to mount this immune response very quickly?
The culprits there that are looked at is the seasonal coronaviruses. So there are a handful of other coronaviruses that come and go and have been present there for many years. So we will have been exposed to those coronaviruses, and at the T-cell receptor level, there is some cross-reactivity against some particular epitopes. We do know there is cross-reactivity. That's what we use to make up our test, because we know that is there in place. Now, in terms of the real descriptive nature of the level of cross-reactivity there, this is still to be resolved, because there are sufficient dissimilarities as well. And surely this is not being enough to protect those very severely affected. I think we're still learning, but yes, there is a background in immunity, because we have already seen viruses of the same family.